Good evening, everyone present here. I am Faraz from Clarnet. Clarnet is very proud to be a part of this session as a digital partner. Clarnet is India's largest live digital doctor-generated learning platform. With all of you, I'm presenting a short video on Clarnet. Thank you so much all doctors for watching the video, and you all are requested to visit our website, that is www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that you can also read. By taking not much time, I would like to invite and hand over this session to Dr. Varghese Thomas, sir. Over to you, sir. Kindly proceed from here.
Thank you for us. Thank you for giving us this platform. And I officially welcome today's faculty, Dr. Charles Panakel. He is the head of hepatology division at Aster Medcity, Cochin. Dr. Charles is a senior consultant and hepatologist in Aster Medcity, Cochin, and he has been kind enough to agree to be the faculty for today's session. And he's a very experienced person who is looking after all types of liver and transplant cases. Warm welcome, Dr. Charles. And I welcome also today's presenters, Dr. Nihal, who is from KIMS Trivandrum, Dr. Namit, again from KIMS Trivandrum, and the two discussants are Dr. Parag from SIMS Chennai and Dr. Sumuk from Madras Medical Mission Chennai. And along with me, Professor Jayanthi will be joining us soon. And I already noticed the presence of Professor Shobna Bhatia from Mumbai. Warm welcome, ma'am, Shobna ma'am. And warm welcome to Dr. Ajit Taragan as well as all other faculty members.
Thank you, doctor. Thank you, doctor. Yeah.
Thank you. Okay, thanks for joining us. And so all other faculty members who are watching how we perform, both faculty as well as the residents, how we perform during the teaching session. So warm welcome to all of you. And the house rules are, except the presenter and the active faculty, all others will keep their video and audio in the switch off mode. All others will keep the audio and video in the switch off mode. Second thing, if a question is asked to any of the presenter or discussant, we give time for the presenter or discussant to answer it. Please don't answer it in the chat box. It is their privilege to answer. Okay, therefore, if of course, if the faculty asks for the answer from the chat box, somebody else can answer it through the chat box. Okay. And please keep the audio and video in the off position because otherwise there will be a lot of disturbance during the class. Now, Dr. Charles, can we start? I am not able to hear you.
Yes, sir. We can start.
Yeah, okay. So, Dr. Nihal Ali, please start the presentation.
Okay. Good evening, everyone. Myself Nihal Ali. I'll be starting today's case. So we have a 50-year-old male who is a telecom engineer by occupation, who was working in Dubai, a resident from Trivandrum. The history given is by the patient himself, and the reliability is good. He presented with complaints of yellowish discoloration of eyes and urine since 1 month. History of presenting illness: patient was apparently asymptomatic 1 month back, when his symptoms began in the form of yellowish discoloration of eyes, followed by he noticed the yellowish discoloration of, first he noticed the yellowish discoloration of urine, followed by eyes. It was insidious in onset. It was gradually progressive and painless. He does not give any history of intake of camps or alcohol. No prodromal symptoms were there prior to the onset of jaundice. Jaundice was not associated with any fever with chills or pruritus or passage of pale colored stools. He does not give any associated abdominal distension or melena or pedal edema or altered sensorium. No history of weight loss or loss of appetite. No history of any rashes or joints. Was a history of burning micturition 2 weeks prior to the onset of symptoms, for which he went to a nearby hospital and they diagnosed him with UTI. And the patient was started on a course of levofloxacin. And he noticed jaundice 1 week after stoppage of the drug. Past history, otherwise, is nil premorbid, No history of previous hospitalization or receiving transfusion or tattooing or undergoing any surgery. No history of similar illness in the past. Personal history, he consumes mixed diet. He consumes mixed diet. He's a non-smoker. He doesn't consume alcohol.
Dr.
No high
Dhruv,
risk.
please mute. Dr. Dhruv Shah, please mute. Paras, please mute Dr. Dhruv Shah.
No high risk
Please proceed.
habits. Diet history is adequate, sir. He consumes about 2,100 kilocalorie intake of with 60 grams of protein. Family history, no family history of liver disease or similar episodes in the family. So to summarize, we have a 50-year-old male who presented with a painless progressive jaundice with no features of cholestasis or cholangitis or symptoms of decompensation.
Can you go back to your first slide?
What is the duration?
Duration is 1 month, ma'am.
See, I have not heard the history. The summary should be such that
we
I
can
understood
repeat
what the
it.
case
Just
is.
repeat the first slide.
No,
First
tell
slide.
me the good summary so that I understand what case you're discussing.
Yes, ma'am. Ma'am, this is
From your summary,
this is a,
1 minute. From your
okay,
summary, I did not understand anything. So
okay,
give your summary in such a way, like I've just joined now. So you must give a summary in such a way that I'm able to understand what you want to convey.
Yes, ma'am. Ma'am, he's a 50-year-old middle-aged man who presented with painless progressive jaundice of 1 month duration, ma'am. Not associated with any.
Doctor, you just summarize. You've finished all the history. I'm not interested. You summarize in such a way that I understand what is going to be your differential diagnosis. That's all.
Yes, ma'am.
Ma'am, I only heard one thing: 1 month progressive jaundice, painless jaundice, correct, no fever, no chills, no. That's all. What is it? What?
Ma'am, so I feel it is what we are dealing. So broadly, I would like to divide into 3 things: pre-hepatic, hepatic, post-hepatic.
No. From your history, doctor, 1 minute.
From the history,
that is 1 minute.
Okay.
All that is in your mind.
Yes,
all that is in your mind. From the history, I should get an information what.
Yes, ma'am.
Ma'am, I'm dealing with.
I'm dealing with a hepatocellular pattern of jaundice, ma'am.
Dr. Nihal,
Yes, sir.
Professor Jayanthi was asking you to rephrase your summary in such a way that a person who just listens to your summary will still be able to arrive at the correct diagnosis. Okay.
Exactly.
Ma'am was not able
to
hear your initial part of the story. Okay, so she only listened to your summary, but she was not able to understand much. So she was asking you to tell the summary in such a way that a person who has not listened to your initial part also will be able to understand or come to some sort of a conclusion. Okay. So try to say that once again.
Okay, sir. Middle-aged.
Go to your summary slide. Go to your summary slide and explain.
A middle-aged male presenting with a painless progressive jaundice of hepatocellular pattern with no features of cholestasis or cholangitis. Onset being onset noticed 1 week after starting of medication. 1 week after starting levofloxacin.
1 week after starting of?
Levofloxacin, ma'am.
Sorry?
Levofloxacin, antibiotic levofloxacin.
But how certain are you it's levofloxacin related?
No, ma'am. It was not related. But apart from that, I could not get any other causation association, ma'am.
See, that's what I'm trying to tell you. When you're presenting this case, I just joined 10 minutes late. So supposing some examiner comes and walks in, I should be able to understand what is it that you want to convey. And you cannot say levofloxacin introduced as one diagnosis in this patient, no cholestasis, nothing. Jaundice that is progressive. I say it is hilar cholangiocarcinoma.
But ma'am, in the history, he doesn't give any history.
1 minute, 1 minute, just to explain to you, don't say but. So I'm saying it's not levofloxacin, it is
Ma'am, in the history, he doesn't give. Yes, ma'am. In the history, he doesn't give any history suggestive of any loss of appetite or anorexia.
What percentage of hilar cholangio will have?
That is true, ma'am. I agree that he's a
percentage of hilar cholangio will have loss of weight and appetite. What percentage?
I'm not sure with the exact percentage.
Dr. VT, just I think this is important. They should give a good summary so that we understand, someone who is just joined to understand what is it that they're dealing with. There's no prodromal symptoms. Patient does not consume alcohol. Because I do not know. I've not heard the history.
Okay. Should I include that also in the summary, ma'am?
Jayanthi, can I ask a question here?
Please, because I just joined, so I need to know what the patient is. That's all.
No problem. So what I want to know is why was the patient on levofloxacin for the first thing, and whether that is linked to the liver disease or it is not linked to the liver disease.
Ma'am, he was on levofloxacin for his UTI, ma'am. It was given by a doctor abroad.
Okay, so he had UTI and then he had
UTI.
That means he had fever, burning micturition.
Yes, ma'am. Yes, ma'am. He had fever, burning micturition.
Okay.
He took this medicines for 1 week.
Okay.
He stopped the medicine.
Okay.
And 1 week later, he noticed this yellowish discoloration of urine first.
So straight away you want to say that this is drug induced.
Yeah.
Ma'am, not exactly, but I could not find any other drug history in his this thing, ma'am.
I'm saying it's not drug induced at all.
Yeah, Nihal, what are the other differential diagnoses you want to consider? Why do you stick to drug?
Yeah, why you
No. Other differential diagnosis I would like to keep is it could be a flare, ma'am. CHB flare.
CHB flare. What is CHB?
A chronic hepatitis B infection patient is having, and now he is having a flare. He's having a reactivation.
What will be the presentation of a flare?
Presentation of a flare. Actually, prodromal symptoms are more marked in an acute hepatitis B than in a reactivation. So they usually present with jaundice, progressive jaundice, which is painless.
That's
and sometimes they may have.
That's how you diagnose a flare. Huh? What are the various presentations of a flare?
Apart from prodromal symptoms, they may complain of a vague.
Other thing, 1 minute. What percentage of patients taking levofloxacin will develop drug-induced liver injury?
No, it is not at all common, ma'am. It is not mentioned in any of the literature.
So why are you harping on levofloxacin as a cause?
Hello?
Doctor, I'll just tell you, when you mentioned this 50-year-old person with progressive painless jaundice, you'll have to say, which was not preceded by any prodromal symptoms, except there's one history of drug intake. It was antedating about 5 to 7 days back for symptoms of urinary tract infection in a patient who does not consume alcohol with a sudden onset of jaundice, which has been progressive in absence of features of cholestasis. And what are the other things that you'd like to mention? No histories. What are the 1 month
in the
history?
absence of an underlying liver disease?
Yeah, in absence of not a known case of liver disease, or is already a known case that we need to know. Then what else will you say? Abdominal pain, fever with chills, all that you'll have to bring in, no?
Yeah, I brought in the history, ma'am.
No. In the summary, you'll have to tell us.
In the summary, okay, yeah. That I didn't. Yes, ma'am.
No, your problem, Dr. Charles, you may take over, but before that, I may just mention the second line of your summary is actually inference. It's not summary. No features of cholestasis, cholangitis, etc. I should not say like that. Okay, this is already inference come now. So you have to simply sort of edit your history and present it in a very concise way, so that in few sentences the gist of the thing is very evident. Okay, with the most important history and very relevant negative. That's all. Okay, over to Dr. Charles to continue.
Yeah, Nihal, good evening. Nihal, you have a 50-year-old gentleman who had no previous history of chronic liver disease, now presenting with insidious onset of jaundice, and that's progressive. You said there's no prodromal symptoms.
Yes, sir.
There's no history of alcohol or cam intake, and
No, sir.
no fever, no abdominal pain, no cholangitis. And
No, sir.
jaundice occurred following a sepsis, urosepsis.
Yes, sir.
Okay. So what are differential diagnoses that you can think of here when you see such patients?
Predominantly hepatic causes, sir. I want to bring in.
Yeah. What do you mean by hepatic causes?
One is this flare of underlying chronic hepatitis B, which he may not be knowing.
No, why
Now
do
it
you,
has-
Madam said, why do you bring in flare of chronic hepatitis B?
More common, sir. In this history, I'm not able to put once a single diagnosis. I'm not able to bring in, sir.
Okay,
Ma'am
Madam
has asked a question.
asked that
What
why
is
do you
that
say jaundice is
progress?
progressive?
Sorry, sir.
In your history, you did not specifically say that the jaundice, the depth of jaundice increased over the last 1 month, unless and until that part of the history there, the initial, was it there?
Yes, sir. No, the reason why I told progressive was that, sir. Actually, when he checked his labs over there, it was
no labs.
like,
No, that is very dangerous. Never say that. This is purely
no.
a clinical examination. No lab business. No tip. Nothing. Okay. It is like getting a tip. That's very
No,
dangerous.
sir, but
Never
the
ever
thing is,
say that.
he's only telling it to me, no, sir. No, sir, like he's an educated person, so he's aware of this.
No,
So
even
that is why
then,
he is told with
you
me.
may get not of side
Yes, sir.
information from the skilled assistant, from the patient himself or herself, or from the bystanders, etc. Okay, but you have to
Yes,
use
sir.
what is useful to you, and at the same time act as though you don't know much of those extra information. Here, did the patient ever tell you
Okay.
that the jaundice increased over a period of time?
Yes, sir. He told it as like he told like gradually his family members is the one who noticed first, and
Okay,
then it became
agreed.
very obvious he was having a jaundice.
Okay, then that part has to be there. The jaundice was,
Okay,
the
sir.
depth of jaundice was more at the end of 1 month.
Yes, sir.
That's it. Okay, over to Dr.
Okay, sir.
Charles. Sorry for that interruption.
Sorry, just a moment.
Yeah,
Dr. Charles, can I take a moment?
Yeah, sure,
You
ma'am.
know, all the students make this mistake. They call it painless jaundice. Jaundice is never painless or
Yes, ma'am.
painful. It is jaundice associated with abdominal
Associated.
pain. So please, that word painless jaundice should not be there. It's the same thing they talk of, painless hematemesis. It's the abdomen that pains, not the jaundice. So just,
Yes,
this
ma'am.
is more of a correction in terms of an English grammar rather than anything else. Okay.
अंग्रेजी हमारा भाषा नहीं इसलिए मैं
Thank you, sir.
Yeah, Dr. Nihal, if you see such patients in your clinic, what would be the first thing? What would be your differential? First 1, 2, 3, 4.
First one, I'll keep it as drug-induced liver injury. Like because it may not be levofloxacin, but it may be some other medicine which I'm not able to get the history of, like which he may be taking, and he didn't feel the need to tell it to me.
Okay.
Like, so that is why I'll keep drug-induced liver injury. I'll keep 1. Number 2, I'll keep possible autoimmune hepatitis. I agree. More commonly seen in females, and he doesn't have any other associated autoimmune disorder, but it can present in a middle-aged man.
Can it be the first decompensation of like underlying chronic disease, liver disease that is not diagnosed before? All this occurred after urosepsis.
Sir, it's been. Yes, sir. Sir, it has been 1 month, sir. 1 month, and it has only presented as jaundice. He has not even decompensated, to develop any what is it, ascites, this thing, sir. So that means this cannot be underlying liver disease.
You are not examining the patient. You just have the history.
But yes, no, sir. There is no abdominal distension. There is no pain. Any pathopathic reverse.
Yeah, as Madam asked, can it be a malignancy,
Yes, sir,
hyalocholangiocarcinoma?
it is possible, sir. It is possible. A middle-aged person, actually, hyalocholangiocarcinoma did not have features of a definite extrahepatic obstruction, like pain, abdomen, pruritus, and all. So that is one of the possibility in this that we have to rule out.
Yeah.
Because the reason I kept it much lower was because otherwise he was like 1 month history, and there was no associated weight loss and those symptoms. So that is why I put it much below.
No, Madam asked you a question, how common is weight loss and anorexia in hyalocholangio?
Yes, sir. That I'm not very sure.
But it's not common, no? It occurs much, much later. The symptoms come on much ahead of your symptoms are far ahead of your anorexia and weight loss. Okay, now in this particular patient, a patient who's having jaundice, there has to be at least some discomfort in the right hypochondrium. In this patient, when I'm examining, at least I may find a palpable liver, or it's possible that he's got an acute pain, colicky pain. So you have to keep, doctor, you have to keep a wide differentials in this patient who's just got jaundice for 1 month.
Yes,
so, supposing I say it's leptospirosis, supposing I say now, okay, my differential in this patient granulomatous hepatitis.
Yes, ma'am.
What question would you ask?
Granulomatous hepatitis, they present.
So that's why Dr. Charles is asking you, what are your DD? What are your DDs in this patient?
Yeah, other than
just list out. Doctor, first and foremost, tell us number one, is it intrahepatic or extrahepatic? Let's start with that. Intrahepatic. You cannot, doctor, never ever be so confident that it's intrahepatic.
No, not like that, ma'am. Like I would like both intrahepatic and extrahepatic. History among the intrahepatic,
what is the points? 1 minute. Intrahepatic more than extrahepatic. What are the points that you would like to say? Why do you say it's intrahepatic and not extrahepatic? And extrahepatic is coming as the next differential. Tell us the points for intrahepatic.
Points favoring intrahepatic are one is that the patient absence of abdominal pain, no history of any fever with chills, no pruritus. Then that's it, ma'am.
That's it. Abdominal pain, how common is it? In extrahepatic, can you have no pain and yet the patient have the biliary obstruction?
Yes, ma'am. Actually, the pain more it comes with the benign causes like choledocholithiasis and all.
No. I'm not asking all that, doctor. I'm just asking you what percentage of patients should have pain in extra. If the pain is present, it helps you to make a diagnosis. But in its absence, it does not negate the possibility of a.
That doesn't negate, yes, ma'am.
Supposing I say it is IgG4 cholangiopathy.
Yes, ma'am.
So what I would like to convey is you have to discuss the case and say that I would like to discuss this patient, the patient who's got jaundice, which is according to the patient is increasing in intensity in the terms of increasing intensity over the eyes. Urine color will always be normal, same color, okay? Only thing that can show and the body becomes more yellowish. That's the only thing that will tell you that the jaundice is progressive. And then say that I would like to discuss this patient as cholestatic jaundice. In that, I would like to discuss few issues in this patient, and then say that I would like to consider intrahepatic rather than extrahepatic for the following reasons. And then mention these are my points for and against. For my differentials in intrahepatic, these are my differentials. However, I cannot dismiss the possibility of extrahepatic as he's 50 years old. And he's come for the first time with no prodromata, some history of a levofloxacin, and presenting with progressive jaundice. And my differentials for these are, you'll have to mention what are the benign, what are the malignant causes, what are the other differentials. This is the way you have to discuss the case. And then shortlist that, and then say the points are 1, 2, 3, 4. That's the way you have to discuss this case.
Okay.
So, Nihal, what would be your differential diagnosis? 1, 2, 3, 4.
Intrahepatic, I would like to consider. I would like to consider DLEs, one. Number 2, I'll consider chronic hepatitis, drug-induced liver injury.
Okay.
Number two, I would like to consider reactivation of chronic hepatitis B.
Now, when you say drug-induced liver injury, what drug are you thinking
Yes,
of?
Sir, any if he has any history of intake of any CAMs.
He doesn't. You specifically said that he has no intake of CAMs, no drugs, and only intake is levofloxacin, which he had stopped 1 week prior to onset of jaundice. How
Yes,
common is it to have a jaundice after you stop levofloxacin? How common is
Yes, it is very
jaundice?
uncommon. No, sir,
And
it's
how common is
uncommon,
it
sir.
to have 1 week after?
Yes, sir.
So
Other
you-
possibility is
you
like
plug into
there must be
sleep.
some other antibiotic which he must have missed. Amoxiclav can cause more of a cholestatic.
What are the other intrahepatic causes that can present like this?
Other intrahepatic causes, sir. 50-year-old. Then should we consider like infiltrative causes, sir?
Yeah.
Like,
What are the benign causes? What are the malignant causes, intrahepatic causes that you can consider here?
yes. One is granulomatous hepatitis.
How common is
like
it
TB
to
or
present with
sarcoidosis.
jaundice, progressive jaundice?
They present.
When you say granulomatous
They'll have
hepatitis,
other associated symptoms. They'll have, sir.
no, when you
like,
say granulomatous
cough.
hepatitis, what are the conditions that you think of?
Sarcoidosis, TB.
Mm-hmm. So, do you think the patient has a sarcoidosis or tuberculosis here?
No, sir. He doesn't have any other associated symptoms. He doesn't have.
Mm-hmm.
There is no history of cough, no weight loss.
Mm-hmm.
He only has one symptom of jaundice. With that,
Doctor, then when you say like this, no, this was your cough, no, it's your fever, they'll just stop and say,
Yes,
doctor, what percentage of patients with tuberculosis disseminated would have presentation like this? So when you speak, you have to give a percentage.
Yes,
Otherwise, it is not acceptable. Okay, it's not acceptable.
Okay.
Yeah.
South Indian sickness किसकी बुखाई
पहली बार ही देखा है इसको
पोस्ट लिखा था अंजलि विश्वरामन नाम है
इसमें सारे कैरेक्टर ना नए हैं एक भी बंदा पुराना नहीं दिखा मुझे कोई
ये कुछ करेगी गड़बड़ मुझे लग रहा है
Somebody talk in the background.
अरे
कौन चलाएगा तेरे पे
अरे इसने ना इसको इसके घर के पासवर्ड पता थे कोयल के घर के इसने बाप के फोन चोरी करवा दिए उससे नीरू से
Can someone
Yes, sir.
take charge of this muting business?
Yeah, somebody has joined and
What
started
nonsense they are talking here? Students, we faculty are behaving, I think, abnormally, with all the students talking the way they want. Look at the way they're behaving.
Okay, we'll forgive them because it was a mistake. Okay, now there's a question by Professor Shobana Bhatia. Can this be viral hepatitis without a prodrome?
Yes, sir. Actually, reactivation generally doesn't
Can be a
come
pakka
very
acute
frequently.
viral hepatitis. Pakka acute viral hepatitis, acute so-called acute infective or acute hepatitis without the classic prodrome. Or the next question automatically will come. How many percentage will not have a classic prodrome and have acute hep A, hep E, etc.
Sir, I think more than 70% of the cases, acute hepatitis B will come with the prodrome symptoms. Whereas in reactivation, prodrome symptoms are not common.
Okay, I think Dr. Charles, let us
Yes.
proceed from here. Yes, I think we are stuck. I think, can you just help them out as to what all are to be mentioned?
Yeah, but see, if I see this patient in OP, the things that I would consider is one would be a chronic liver disease with decompensation in the form of jaundice. And even though he doesn't give any history of underlying past history of any liver disease. And second possibilities would be drug-induced liver disease. I would think of autoimmune, and then NASH with decompensation, hemochromatosis, and then think of malignancies because as ma'am said, hyalocholangiosis can present with jaundice alone without any other symptoms. And again, extrahepatic cholangiosis, distal cholangiosis, again, did not have the classical fever, fever chills, and other classical features of uh, extrahepatic biliary obstruction. So all this would be a differential diagnosis in this patient. It's a 40-year-old, a 50-year-old with probable underlying NASH related liver disease, and he's had a UTI. It can always be a first decompensation form of jaundice. Yes, can we continue?
Yes, sir.
Okay, we have a discussant also. We'll ask them. Who is discussing? The first discussant?
Parag.
Dr. Parag. Dr. Parag.
Yes, sir.
Your differential diagnosis from the history. From the history.
From the history, I will consider intrahepatic more than extrahepatic, sir. Since the patient doesn't have any abdominal pain or any prodromal symptoms, intrahepatic, I'll consider drug-induced liver injury, sir. Though the levofloxacin is not that common to cause drug-induced liver injury. The second possibility I would like to keep is autoimmune hepatitis, sir. Having said that, I'll consider the extrahepatic causes, sir, like cholangiocarcinoma or periampullary carcinoma, sir, because they don't present with abdominal pain with a progressive jaundice, sir.
So you would consider parenchymal liver disease intrahepatic causes more than extrahepatic. Okay. Possibilities were mostly autoimmune hepatitis.
Autoimmune hepatitis, sir, and drug-induced liver injury. The third possibility will be hilar cholangiocarcinoma, sir. And the fourth possibility I'll keep as periampullary carcinoma, sir.
Dr. Sumuk, you have any other diagnosis?
No, first possibility will be first decompensation, first episode of decompensation of underlying chronic liver disease. Sir. Second can be drug-induced liver injury, sir. Third can be autoimmune hepatitis, sir. Fourth, other intrahepatic malignancy of intrahepatic cholangiocarcinoma can also be one of the possibilities, sir, intrahepatic. In extrahepatic malignant causes can be distal cholangiocarcinoma or a periampullary carcinoma, sir. These cannot.
Okay, now
I say the possibility of nodes at the porta is a non-functioning NET, and the patient has got actually a nodes at the porta, and that is presenting as progressive jaundice. The primary is silent. Patient has got fatigue, he's got tiredness that I don't think you've mentioned, and there's actually a colonic malignancy there. I do not know. History is not forthcoming. And the patient has got nodes at the porta. Is it possible that the patient is having progressive jaundice according to your history taking? Doctor,
Yes,
please, what I'm trying to tell is, what I'm trying to tell you is just have a wide differential, doctor, so that when the report comes, as we tell you the investigations, we'll come to a diagnosis. And you said the patient is educated. Did he have any investigations done during his course of
he got it
evaluation?
done.
So what was told to him? At least some clue would be there. Or he says that I do not know what was the diagnosis and I've been referred to a referral center. For you, that if the patients come to a tertiary referral center, it's only for management.
Correct, ma'am.
It's not for diagnosis. This again, I want to reiterate. If you go in the present days, all the candidates are going to corporate hospitals with all diagnoses ready. So the discussion is heading towards the management. So you said he's educated, so he's able to tell you the bilirubin value that has escalated from this to this.
Yes,
Do you have any further information that he had an imaging done and he was told that he needs to go to higher center for management, something like that? Then at least you can.
That is the reason.
That you have to bring out in the history, doctor. I'm telling you again. If you go to this last exam that we had, both the centers which I went to were all corporate centers, and both the centers had all the diagnosis. Patient says that I have this disease, I have achalasia cardia, and I've come for management. You understand? So certain things, educated person who's coming to a tertiary or quaternary referral center, when he comes with a diagnosis, he's come to only for management. So you can, I think you should, Shobana and Dr. Varghese and Dr. Charles, I think you should comment on this, because they come to these centers for managing, and then the history goes by the way. The history will be for which he was investigated. He had some baseline blood tests, also in imaging. And then based on the findings that she was told, he's being referred to the highest center for further management. To some extent, you have to give some information that will again help us. You understand?
Yeah.
Okay,
It's
ma'am.
very important
Understood.
because I remember we had case of Wilson disease in Hinduja, then we had a case of achalasia cardia, we had a case of everything. All the cases were all known cases. Carcinoma esophagus, management. So what's the point? I mean, so especially when they're educated and all the high-fi people are coming to these corporate hospitals. I'm just telling you the pattern of examination that is taking place. So sometimes you may not stop at the history at all. What we did as the days went on, we just said, let them speak for 5 minutes and let us go quick to examination in this. So in that context, you said he's educated. Can we get some information on his evaluation that he had, whatever he had?
Yes, ma'am. Actually, he had underwent, he did LFT as well as ultrasound abdomen, ma'am.
So that gives us no information. Okay. Beyond this, does he know what he's having?
No, beyond that,
he
actually,
does
they
not.
didn't do anything.
That's
He
all.
immediately took a flight and he came down to Trivandrum.
No, he's taken a flight and come to Trivandrum for high-end evaluation or high-end management.
Yes, ma'am.
He was abroad, no? He was abroad, Gulf, no?
He was in no, ma'am. They didn't have this thing, man. Yeah, he was in the Gulf. He was a telecom engineer working in the Gulf.
So he
So that
didn't
is why
want
he did a baseline.
to
Moment he noticed
investigate
jaundice, he did a baseline test and he came over here.
Okay, now just continuing with what ma'am said, if the patient comes and tells you the diagnosis, or if it is a known case of such and such a problem, issue will the discussion will hover mostly around the management, because the diagnosis is already known. We won't discuss about the threadbare about this history part and all those things. Definitely, it will be management oriented discussion. If it is a known case and come with a new problem, the diagnosis of the new problem, like a new complication or the management of the new complication. So if the diagnosis is already well known or already told by the patient, the discussion will hover mostly around management only. Okay.
Now I'll just add on one thing. Suppose he goes, don't say that he went to the doctor, he had baseline. So he has had baseline evaluation. Further details are not known to the patient, just stop there. And he's come to here for further management as jaundice did not subside. So now again, we're in a conundrum as we do not know what it is, whether it's intrahepatic, extrahepatic. Okay, now move on.
Now, just I want to ask Dr. Charles and Jayanthi ma'am also, because we were considering decompensation of chronic liver disease as the potential cause of this jaundice for 1 month in the absence of any historical abdominal distension or pedal edema or altered sensorium or GI bleed. So if the candidate says like that, will some of the examiners create a problem saying that in the absence of other components of the history of decompensation?
Yeah, I think for us, it's more of a GI bleed and ascites.
Okay, so if after physical examination, if there are some clues towards a decompensation, I should say it should be kept in the DD. But in the absence of on physical examination, nothing there to say that it's chronic liver disease, perhaps it is not considered in the DD at all. That will be the simple clue. Okay, because you have the advantage of physical examination also. So you have the composite diagnosis with you. So at the end of the physical examination, you know what it is. Okay.
Okay, Dr. Thomas, just a quick one. That ACLF is always diagnosed after investigations. You need some investigations or at least clinical findings to say that there is an underlying chronic liver disease. The second thing, in this patient, there's only jaundice. If this patient had underlying chronic liver disease, by the end of 1 month, there would be at least some distension or edema that would have come up.
Okay, over to Dr. Charles.
Yeah,
proceed further.
Nihal, please continue.
Yes, sir. Yes, sir. So on examination is moderately built and nourished, height of 166 centimeter, weight of 66.2 kg, BMI of 24 kg per meter square. He is conscious, oriented to time, place, and person. Pulse rate of 72 per minute. Right radial. Blood pressure of 110/70 in right arm supine position. General physical examination. Otherwise, apart from icterus, rest of the systemic examination, rest of the general physical examination was within normal limits. Systemic examination, GI oral cavity was normal, no nickel. That was also normal only, sir. Liver was and spleen were not palpable. Gallbladder also was not palpable. There was liver span was 14 centimeter. There was no shifting balance. normal bowel sounds. Per rectal examination also was normal.
So jaundice in history and jaundice in physical examination, nothing else.
That's it, sir. There were no findings.
So after the physical examination, do you want to narrow down your differential diagnosis or expand upon it?
Sir, I would like to not consider a decompensation of a chronic liver disease. The
Okay.
points are like clinically he doesn't have any other features of decompensation if we consider it as decompensation.
So can
No
we totally
stigmata.
rule out chronic liver disease completely? Some form of chronic disease. It need not be cirrhosis liver.
Yes, sir. That we cannot rule out, sir.
So any disease which has been there for more than 6 months is technically chronic, no?
Yes, sir. Yes, sir.
Okay, and it can be silent also and present for the first time at some point in the history. So you can't say that I will totally rule out chronic liver disease. You can probably say
I'll keep it
it's
much
less
lower.
likely. Never ever say I
Yes,
will
sir.
rule out and all in the examination. Okay, say it is
Okay,
less
sir.
likely, more likely. You would be diplomatic.
Okay, sir. So,
Does
so
it rule
CLD
out
decompensation.
extrahepatic? Now, does it rule out extrahepatic?
Can you rule out
Yes,
extrahepatic?
ma'am. There was spleen also was not palpable.
Extrahepatic.
Is that a point? Spleen not palpable. That's a point for extrahepatic.
Oh, sorry. I'm sorry. I was thinking of extrahepatic portal. So extrahepatic, we can rule out because gallbladder was not palpable, ma'am.
We are telling in great length about hilar cholangiocarcinoma. No? It is the most likely thing in this case, if at all, because there is not much of cholestasis, not much of pain.
Sir, features favoring extrahepatic on clinical examination, a palpable gallbladder, then actually pruritus, skin marks.
No, this is after physical examination. No more history.
Yes,
after physical examination, will you? Yes, you said we will
still
rule out
hilar cholangiocarcinoma
please
cannot be
listen,
ruled out.
please, Nihal, please
Yes,
listen.
sorry, sir.
Never ever talk when an examiner is talking to you. Rule number 1. They will get irritated.
Yes,
this is a class,
yes,
therefore we are not irritated. But if it's an examination, they will be very antagonized. Okay. So never try to overpower an examiner by raising your voice. Listen and then answer. That is the safest bet. Because you have not heard what he is going to tell. Okay. Probably he is saying, he's trying to tell something to help you out. But you are not allowing yourself to be heard.
I understood.
To hear it. Okay, so you first told it is unlikely to be decompensated liver disease. We agreed. Now you have to say whether it is likely to be extrahepatic still, extrahepatic biliary obstruction.
Sir, with physical examination, I cannot totally rule out the possibility of an extrahepatic because if the lesion is in the hilar cholangiocarcinoma, still gallbladder won't be palpable anywhere in that case. So hilar cholangiocarcinoma is
TB medicine
There's one more Varghese Thomas, you know.
Yeah, I know. Today I'm Havishnu. Paras, please mute that Varghese Thomas. Paras, please.
And remove him. Take him out. I say there are notes at the quota. Don't mute Dr. Varghese.
Yes, sir. There are lots of with same names, sir. That's why I got confused, sir. I have muted him, sir. You can continue, sir. Sorry for the inconvenience.
Okay, I will keep my video on, so there is no confusion.
Fine.
Yes, sir.
And
sir, I am making you the sir. I am also making you the co-host, sir. You can also.
So I can manage. Please
sir,
make
you can see. Fine,
okay.
sir.
Doctor, one is hilar cholangio. Can it be nodes at the porta?
Nodes at the porta, ma'am. Ma'am, clinically, I could not feel any other.
How often, doctor, you find nodes at the porta?
I know.
I'll tell you what's happening. You know, your attitude is, this is the patient. He's got jaundice there. He's got jaundice here. Now let the examiners beat around the bush to say what it is. Don't get into that mode. That mode. We are asking a very simple, straightforward question. A liver that's not palpable, deep jaundice, no other findings.
Yes, ma'am.
What are your differentials? One is intrahepatic. You're not changing the differentials there. But the extrahepatic,
among extrahepatic, hilar cholangiocarcinoma.
You see, just what VT said, you know, you're talking in between. So one is, we said hilar cholangio, number 1. Number 2, What are the other causes?
Number
can
two
it be,
is the
can
lymph
it be,
node.
1 minute, doctor, can it be IgG4 cholangiopathy? Can it be autoimmune
Yes, ma'am.
cholangiopathy? Can it be AIDS-related cholangiopathy? What will be the presentation? What will
Yes,
be the
ma'am.
presentation of all these?
Ma'am, IgG4 cholangiopathy will be having an associated IgG4 pancreatitis
Really,
or
100%?
other manifestations of IgG4 disease.
100%?
No, ma'am, need not always be there. Other like
So in
other
other words, what I
associated
would
this thing
like
we'll have
to,
to look.
1 minute. In other words, what I'm trying to tell you is, based on this finding, still extrahepatic cannot be excluded. You
Yes,
have to keep that possibility. Okay.
Yes, ma'am.
Dr. Charles, kindly proceed.
Yeah, Nihal, how do you identify GB?
Yes.
Just a clinical question.
Sir, actually, gallbladder palpation should be done in supine position. Sorry, sir, it should be done in standing position. Gallbladder will be more visible. Will be appearing as a globular.
Standing position, you look
Yes,
for the gallbladder, is it?
That is what was told me.
No.
Maybe my this thing is wrong.
Textbooks of medicine.
Okay. Sorry, sir. Okay, it'll appear as a pear-shaped globular mass in the right the right hypochondriac region.
Describe the gallbladder.
Then it'll be below the right ninth costal cartilage, and will moving with respiration. A pear-shaped globular mass below the right ninth costal cartilage and moving with respiration.
What will be the plane of the mass and what will be the intrinsic mobility? Okay, we'll move on. I think we'll just move on. Should we move on?
Yeah, Nihal, actually, this transverse intrinsic mobility, it's better seen than felt. Okay.
Yes, sir.
It's felt with respiration, and you can hook it with your fingers. Okay.
Yes.
Yeah, carry on, please.
The other systemic examination was unremarkable, sir.
No, just
Okay, just before the lab, we will ask the other two. So, Parag, do you want to change your diagnosis after physical examination?
After the slide, you should have actually had your differentials.
Okay, ma'am.
Okay.
Yeah, other two.
Yes, sir.
Parag?
Yes, ma'am. Yes, sir.
Yes. Do you want to change your diagnosis?
After the examination, I'll still keep the differentials as intrahepatic and extrahepatic. I'll both consider both the causes, sir. After the examination, we cannot surely rule out the extrahepatic causes, sir. That's why.
So you mean to say everyone was using intrahepatic and extrahepatic frequently. So you mean that it is a biliary obstruction? That's what you are meaning?
Yes, sir.
So you don't consider parenchymal liver disease as such?
No, sir. First, I'll consider intrahepatic causes involving the parenchyma of the liver, sir. Like autoimmune.
Then because you're telling intrahepatic, extrahepatic is actually confusing me. Generally, we use intrahepatic, extrahepatic in terms of a biliary obstruction. That is intrahepatic cholestasis or intrahepatic obstruction, extrahepatic obstruction like that. For parenchymal liver disease, we generally say like a parenchymal liver disease or a hepatocellular disease. Okay. So make it very clear. So you are considering a parenchymal liver disease or a biliary obstruction. Make it very clear.
Yes. I'm considering both, sir. Can be parenchymal liver disease or can be even biliary obstruction also, sir.
What's your first possibility?
Based on all the history and examination, first possibility is the parenchymal liver disease, sir.
What are your features to say biliary obstruction here?
1 month history of progressive jaundice, sir.
What are the other factors when you say cholestatic jaundice or obstructive jaundice? What are the things you expect?
We generally expect a patient will have pruritus or will have pale colored stools, which he is not having, sir.
So you have associated features like a pruritus, you have plaque stool, you might have features of this long-standing, features of fat soluble vitamin deficiencies.
Yes.
So you're not finding any of this here.
Yes.
So you consider a cholestatic liver disease here.
I'll still keep it as a DD, sir, because some of the patients can present only with jaundice without features of pruritus or cholestasis, pale colored stools.
Okay.
A word of caution. I will give it to be a word of caution. If the clinical picture is totally absent, and if you keep as number 2 differential diagnosis, examiners may, and if it turns out to be correct, examiners will feel little upset. So probably it can be kept towards the fag end of your list. Then it will be safe, because there is nothing to suggest a biliary obstruction in this patient. And if you keep it as a first and second diagnosis, things will be little difficult. Agreed, cholangiocarcinoma can present without any of these and present only with jaundice. But I think you consider that after exhausting parenchymal liver disease, which may fit in with this history and physical finding.
Yes.
Sumok, do you have anything else to offer?
No, sir.
Okay, can we proceed? Now, I think now Parag will have to tell us how you investigate, and then we will show you the investigation.
Sir, I'll ask investigations for the diagnosis, sir, and investigations to for management. For investigations for diagnosis, I'll ask for a liver function test, sir, which will tell us the pattern of the bilirubin, as well as it will show whether the pattern is obstructive or it's hepatocellular. Next, I'll ask for a complete blood count.
Before you go to the next question, first is on the basis of the liver profile, how do you differentiate extra from intrahepatic liver disease?
Extrahepatic causes will have raised alkaline phosphatase and GGTs, ma'am.
You mean intrahepatic cannot have raised alkaline phosphatase and GGT?
It will be in thousands, ma'am. The alphos will be in thousands.
I don't think that is a differentiation at all, because it's extremely difficult in some cases to differentiate the two. And this is already a disease which is 1 month old.
Yes, ma'am.
The hepatocellular insult may actually have gone down in some cases. Whatever the reason, it is in some cases extremely difficult to tell the cause of liver disease just based on the liver profile.
Yes, ma'am.
So you will have to think of something that is a little more specific.
Yes, ma'am. Since
what is the R value?
Sir,
what is R value?
We'll calculate the Rucum score, sir.
No, in what is R value?
In drug-induced liver disease.
Yeah, can be in.
What is it, a ratio?
It's we'll see ALT and alphos, ma'am.
So, how does it help in differentiating different types of drug-induced liver injury?
It will. I'm not sure, sir.
What is this cutoff? Less than 2, 2 to 5, and more than 5?
3. More than 5.
Because your first diagnosis was Delhi, no?
Yes, ma'am.
More than 5.
So you expect it to be more than 5, hepatocellular. Yeah, 2 to 5 will be mixed. Okay.
Okay.
So what will be your next investigation after LFT?
I'll ask for a complete blood count, ma'am, because he was having
You said
infection.
diagnostic, no? You said diagnostic. I'll do
For
LFT first. And then?
For diagnostic, I'll ask ultrasound, ma'am.
So what are you looking for an ultrasound?
Whether any intrahepatic biliary radical dilatation is there. What is the parenchyma of the liver looking like?
Trace the biliary tract. No, you can have IHBR dilatation, then come down. What else can happen?
We can have a dilatation of the CBD, ma'am.
CBD, yeah. Then you can have dilatation of the pancreatic duct.
Yes, ma'am.
Then you can have a double barrel sign, you can have a cigar butt sign. All these signs you look for when you look at the gallbladder, with stone, without stone.
Yes, ma'am.
And focus your attention also to the porta.
Yes, ma'am.
So when we ask a question like this ultrasound, you have to tell what you're expecting. And then say that in its absence, then I look at the liver and look at the surface irregularity and look for any space occupying lesions in the liver, which
Yes.
can be hypo, it can be iso, or it can be hyper-echoic.
Yes, ma'am.
So can we have that report?
Yeah, please. The reports, please.
Hemoglobin of 13.
Okay, Parag, please. Interpret.
Yes, sir. The labs which are presented here looks normal, sir.
Okay, next one. Next.
The total bilirubin was 19 with direct hyperbilirubinemia, sir. AST was 394 or 393 and ALT was 400. Alkaline phosphatase was 102. GGT has not been mentioned, sir. Albumin was normal, sir. Globulin was also normal. There is a coagulopathy in the term of mild elevation of INR in 1.7.
So what is the patient suffering from? What's your interpretation of the INR and the electron?
Looks like hepatitis, ma'am. With raised AST, LT and normal ALP. Along with coagulopathy also in the form of raised INR, ma'am.
So what is he suffering from?
Looks like he is having underlying chronic liver disease, ma'am.
What is there in the what is
What
there in
is
this
the underlying chronic liver disease?
Coagulopathy.
Is that a feature of underlying chronic liver disease?
Ma'am was repeatedly asking you one question. The answer was there. What is it? Look at the bilirubin. Look at the INR and short history 1 month. What do you call that? No clinical features of decompensation.
What is ALI?
You said, how do you interpret that bilirubin there? Total and direct?
Here direct bilirubin is 15, sir. And total bilirubin is 19. So we can say that it's a direct hyperbilirubinemia, sir.
So what about the INR there?
Sorry, sir, I didn't get the question.
Okay,
No.
you said it is direct hyperbilirubinemia, suggestive of.
You're
The
saying
injury is
cholestatic.
where?
Parag, you're saying cholestatic jaundice.
Yes, sir.
Cholestatic jaundice.
It's not cholestatic, sir. It's hepatocellular because
it is hepatocellular, and then this INR is elevated 1.7. So how do you link this together? And what is, I would say, what is the syndrome known as? Anyone else?
We can say acute and chronic liver failure, sir. ACLF, we can say.
Liver failure.
No, why do you
Can
say
it be
chronic?
simply acute liver disease?
Acute liver failure.
Acute liver injury.
Acute liver injury, yeah. Okay, proceed.
ANA was anti-LKM was negative, ASMA was negative, and IG was elevated, sir, 1990.
Next, we'll go through all the tests.
Ultrasound showed normal liver with a normal size measuring 14 centimeters, sir. Rest of the organs, gallbladder, CBD, pancreas, and spleen were normal.
Okay, next one.
MRCP showed normal liver, sir. There was no intrahepatic biliary radical
What
dilatation.
was the eosinophil count?
3%.
What percentage?
3%.
3%.
Okay.
Gallbladder showed minimal wall thickening. Lumen was clear, and spleen and pancreas were normal, sir.
So what should you do now? What
Okay,
should I do
already
now?
it has come out. Liver
No.
biopsy.
Would you do a liver biopsy in this patient? And why do you want to do it? And what's your interpretation of raised IgG?
What do you-
How will you manage this patient at this stage? You've got LFT, you've got, would you ask for an MRCP in this patient?
Was
No,
MRCP really needed?
Alkaline phosphatase normal.
No, sir. It was
No,
not
sir.
because ultrasound
Not
was not.
Okay, what next? The question is, will you do biopsy or not? The my
Or-
master question.
Or will you go straight for a management?
Do you want a biopsy? Yes or no?
yes, sir.
For what?
Do you have enough criteria to diagnose it otherwise?
And how is it going to change your management by doing a liver biopsy?
Well, there may be a slight difference of opinion between specialists because centers with access to transjugular, etc., or they'll do lot of liver biopsy, may do liver biopsy to be absolutely sure and also to explore other differential diagnosis. But normal clinicians may just depend upon lab value like Na2 plus, IgG elevated, and the clinical picture. Over to Dr. Charles for your comments because the residents have not made a comment. So, what about liver biopsy? Should we do it or not?
Yeah.
Dr. Charles?
Yes, sir. At least in our practice, we'll definitely do a biopsy, sir, before starting him on steroids. But Nishal, I just want to ask you what are the features to say he's got autoimmune hepatitis?
Elevated
You're asking me, sir.
Can you make
Do
a
you have
diagnosis of
enough
autoimmune
criteria?
hepatitis without a biopsy?
Do we have the criteria satisfied here? Any of the criteria?
No, sir.
Okay. Why do you say so? Na2 positive, IgG elevated. What else you want?
Viral markers. Viral markers.
All negative. So
All negative.
Then
alcohol negative. Actually, Wilson's.
probable.
We didn't find any Wilson profile in the lab, no?
No.
Probable that can be
You should have been also done, no?
In this
Dr.
patient,
Charles? Yeah.
patient, after doing liver biopsy, how is it going to change your management? And first is what are you expecting on liver biopsy in this patient? What is it you're expecting on the liver biopsy in this patient?
Separate. If autoimmune hepatitis is suspected, then
I'm
interface
asking you, what are the findings you expect in this patient to help you with your management? One possibility, I may just get bilirubinostasis, no? That's all. There may be some canalicular stasis, and there may be some stasis within the hepatocyte, bilirubinostasis. It's not going to change my management. That's number one. Number two, I may find there's some ductular proliferation, which may again say, oh, it may be IgG4 related, some problem actually in the biliary system. If I find eosinophils, it may help me. But is it possible that you're going to pick up any chronic autoimmune hepatitis in this patient? It's 1 month history. Please discuss. See, it's an invasive procedure. Your INR is 1.7. Okay. We have points for and against. By doing a liver biopsy, A, what is your expectation and how is it going to change your line of management? Cannot be quiet. One of you speak. Three of you are there.
Okay, all the three.
Any liver
Nihal,
biopsy,
okay.
sir, liver biopsy will be able to tell us one is any other confounding factors are there, like daily precipitating an autoimmune hepatitis. Second thing is that though not in this case, any overlap criteria you will be able to identify. Like,
Alkaline
for example,
phosphatase gamma GT is normal. Doctor,
yeah, it is,
keep the biochemistry in mind. I'm asking you a simple question. This patient
Yes,
has come to the OP. He's got 1 month history of jaundice, non-progressive, and overall it fits with some hepatocellular with a high bilirubin. That's all. With a normal albumin, everything is normal. He's just within the 3 weeks. By doing a liver biopsy, what is it that you're expecting the pathologist to tell you, or what are you looking forward, which is going to change the line of management by giving you a definitive diagnosis so that you can triage the management towards that particular finding. That's all I'm asking.
yes, sir. Ma'am, in autoimmune hepatitis, findings that we'll see in a liver biopsy.
Does this patient fulfill all the criteria for autoimmune hepatitis?
Ma'am, in the simplified score, you need a score of 7, ma'am, for the diagnosis, definite
I'm not
diagnosis.
asking theory. In this patient, how is it going to help you?
Then we can start
What I
treatment
would
with
do is I would
steroids.
just manage the patient. I'll wait for
Yes,
2
ma'am.
weeks. It's only 4 weeks. I'm in no hurry.
Yes, ma'am.
I'll just watch what is happening to the patient after 2 weeks with my usual regular supportive treatment. The drugs are withdrawn, and just see what happens to the patient and see whether he just resolves. If he's further progressing, he's worsening, then of course I have to push him for a diagnosis. 1 month is too early, as far as I'm concerned, to consider any other possibility with a normal ultrasound and a normal MRCP.
Ma'am, I had one doubt, ma'am.
Yes, please.
Sir, considering that the patient already is having an acute liver injury, early treatment is necessitated, no, sir? I mean, early treatment in a sense, identifying the diagnosis and suppose if it's autoimmune hepatitis, to starting with steroids so that he doesn't progress into acute liver failure.
We will not, your body going to monitor him. No?
Yes.
There are no collaterals. There's nothing in this thing to say he's got chronic liver disease, nothing. 1 month history of jaundice.
No.
But there's one entity called non-A to non-E. There's one entity that has been described recently where all viral markers are negative. It's called as non-A to Z. None of the viruses. But there are some patients who have this classical hepatitis, almost behaving like viral hepatitis, and they have cholestatic features. And over a period of time, they just start resolving. All of a sudden, they just come down. All markers, all evaluation, entire evaluation is negative. So you have to read that. There are recent papers now. Actually, this came up for one of the plenary session as one of the papers. Non-A to E, complete, all CNV negative, EBV negative, all viruses negative, all etiology negative. But there are these small proportion of patients, they have not come out with what numbers. But in that particular series, they picked up about 8 cases which had none of the markers positive, and yet it was acute hepatitis. So you need to quote that. You have to read that paper.
Ma'am, what Nihal was trying to stress is probably the INR was elevated and the bilirubin is also on the higher side.
I'll
give
vitamin K for 3 days and wait. The 1.7 is nothing. It's not 2.9. It's not 3.2.
Okay, now I think regarding liver biopsy, there are different schools of thought. I have to make it very plain, especially hepatology units, especially aggressive hepatology units always do biopsy because they have access to transjugular liver biopsy, and therefore coagulation failure is not a major issue for them, and therefore go out with liver biopsy and try to be sure of what they are dealing with. So suppose this case was in Dr. Charles' unit, how would you manage? We would like to hear.
No, we would definitely biopsied, sir. Because the patient has got a hepatocellular jaundice, high bilirubin, INR is 1.7 now, which is a bit worrying for us. And we would definitely biopsy. And if biopsy shows features of autoimmune hepatitis, like interface hepatitis or lymphoplasmacytic infiltrations, then we would definitely start him on steroids.
Now the question now comes about what ma'am asked. Can you just make a clinical diagnosis with available points and start on steroids? Will it make a difference by doing a biopsy?
In this patient with so much bilirubin of 18, and in my practice, I wouldn't start him on steroids because without a diagnosis.
Okay, because we are going to take a long time commitment of treatment with steroids. Okay, so we want to be absolutely sure. So our students remember that there could be slight difference between examiners regarding this. You have to be sufficiently diplomatic. Okay, especially when you say percutaneous liver biopsy, etc., with even if it is slightly altered, deranged INR, you have to be careful. Transjugular perhaps we can do without much problem, even in presence of severe liver failure. So you have to be very careful about it. Okay, now I think we won't discuss much about the dosages because it was discussed by Professor Venkatakrishnan in the last class. I think we had a very
look
detailed.
at the biopsy report.
Okay, we can look at it. Okay, yes. High power.
They have done an ultrasound guided.
Ma'am, actually, like you told that when we gave vitamin K, that INR came down, ma'am, to less than 1.5. That is why UST guided biopsy itself was done.
Let us know what it was.
Yes, ma'am. So there was a lymphoplasmacytic infiltrate. I'll take a bigger picture of this. There was hepatocyte ballooning. There was like this dark blue cells with the perinuclear halo were lymphocytes, and and eosinophils also were there. The pink cells which are marked, there were some cholestatic biliary plugs also were there. So actually, yes, ma'am. So actually, that drug-induced liver injury component favoring things were the eosinophils and this one, and favoring autoimmune hepatitis was the lymphoplasmacytic infiltrate. Spotty.
Lymphoplasmacytic infiltration is not a feature of drug-induced. Okay.
No, ma'am. I'm saying autoimmune hepatitis.
It's just no. Autoimmune hepatitis.
Okay.
It does not mean that autoimmune hepatitis will just have a lymphocytic and plasmacytic infiltration. Unless you have other features, how do you say it is autoimmune?
No, interface hepatitis also was there.
What are the features of autoimmune hepatitis?
Interface hepatitis, then emperipolysis, that is basically the drop in the hepatocyte count at the interface plate. Then basically lymphocytes will be there within the hepatocyte will be having a lymphocyte within this thing. That correct, no, sir?
Yeah.
Why did they say the possibility of drug-induced liver injury to be considered? What are the points on a liver biopsy?
Yes. One is increased eosinophils, sir.
Okay.
Then that cholestatic biliary plugs.
Okay. Only eosinophils are second. Can you have
cholestatic biliary plug does not tell anything, doctor. It is just indicates biliary
part of an overlap. Because in histology, especially 20 to 25% of AH will have some sort of a cholestatic picture, no? So with that, probably you cannot immediately make a diagnosis of that. But I think that eosinophils are there and possibly cholestatic plugs are there in the presence of parenchymal inflammation. First is autoimmune disease with some histological overlap, I would say. Second one is drug-induced liver disease can be considered. Dr. Charles, what is your opinion?
The first possibility would still be autoimmune liver disease with the ANA positivity, high globulins, and you're seeing interface acuity and lymphoplasmacytic infiltration. Even though we are not.
Is it drug-induced autoimmune hepatitis? Is it a drug-induced autoimmune hepatitis?
Can we clinically or by any other lab test or histology definitely say it is drug-induced AH? Is it possible?
Eosinophil.
Yeah.
So that will be.
Yeah, eosinophils. Presence of a lot of eosinophils in the histology specimen, histopathology specimen generally points to the fact that it could be drug-induced. Okay, anything else in the investigations?
What was the level of ANA? What was the
2+.
level?
2+.
2+. We need to know the title. 1 in 100, 1 in 180.
Yeah.
2+.
Correct title.
2+ and 1+.
Do you have any other slides, Nihal?
So how to manage this patient?
We had started on steroids as per Sheila Sherlock regimen. We started on 30 milligram, reduced it to 20 milligram, and then 15 milligram at that time. Azathioprine also was introduced. Prior to that, starting azathioprine.
What are the chances that without steroid? 1 minute.
Sorry, ma'am.
Don't wrap it up. Okay. What are the chances this patient would have recovered even without steroids?
Even without steroids, ma'am. If autoimmune hepatitis is the predominant, because features of autoimmune hepatitis.
You never showed interface hepatitis, okay? There were only lymphocytic plasma cells, and there were some eosinophil cells and some ballooning vectocytes. Anyway, I think we go for management and then conclude the session.
Yes, ma'am. We started the patient as per Sheila Sherlock regimen. Prior to starting azathioprine, we also checked the TPMT activity also. And then actually, like the recent follow-up, it showed a gradual decline in bilirubin. The last bilirubin on follow-up was 2 from 19. And we've been tapering the doses of steroids. Right now, patient is on, last follow-up patient was on 15 milligram only of steroid. Idea is to get it down to 10 milligram and continue azathioprine. 10 milligram of isolon should be continued for a minimum period of 18 months.
So in a kindergarten case of autoimmune hepatitis versus drug-induced autoimmune hepatitis, is there any difference in the regimen? This patient will be on long-term azathioprine for 1 levofloxacin-induced.
Actually, we can even consider for monotherapy, no, ma'am. Monotherapy as per ASLD.
No, you have to be very clear, doctor, what are we dealing with, no? So if it is drug-induced and you think it is levofloxacin-related, what should be the treatment protocol for this patient? You give steroids.
Yes, ma'am.
Then what do you do? You give start azathioprine, then what do you do?
Ma'am, actually, to differentiate whether it is just a daily triggering an autoimmune hepatitis, when we taper the dose of steroids, if it was a daily triggering autoimmune hepatitis, then it will flare, like you'll have a relapse on reducing the dose of steroids.
That's it, that when you reduce the dose of steroid, you'll have flare after the drug has been stopped in drug-induced. I do not know.
No, I think what he mentioned was that there are 3 possibilities where a de novo autoimmune disease can present. A de novo DILI can be there, or an autoimmune disease which is precipitated by a DILI. So it will apparently like an autoimmune disease, but the background precipitation is probably by a drug. It will look like AIH. And usually such DILI, drug-induced autoimmune hepatitis are self-limited and settle down fast compared to the classic autoimmune disease. That's what the literature says, and that's what I think is the general observation. Is that what, ma'am, you wanted to say?
I do not know. I just want to know, will there be a difference in the regimen in a patient which is drug-induced, levofloxacin related versus a de novo autoimmune hepatitis? I do not know.
Generally, if it is sure that it is a drug-induced liver autoimmune disease, I think the duration of treatment is shorter, and we try to reduce the steroids faster and stop. Dr. Charles?
No, if you're sure that it's a drug-induced autoimmune hepatitis, then we can taper and stop the steroids and follow them up for relapse. And in case they relapse, then we have to, but we have to keep them on close follow-up for relapse.
I do not know the guidelines.
No, there are no guidelines on that, man. There's no guidelines on.
Yeah, that's what. So I'm not clear about it. I think the students can just look up, because this question will be asked, because this is one. And also tell the patient that any of the ofloxacin, all these drugs can cause hypersensitivity reaction. So you have to be very careful in telling the patient that you had one problem. We do not know. It is levo, it is de novo, nothing. We have no idea. But you have to at least tell him that levo has caused probably a problem, and just be sure that you don't take any of the other the other drugs belonging to the same category.
Yes, ma'am.
Dr. Ajit, you are there, no? Please try to help us by finding out whether
Please
there
look
are
up
any
single
criteria.
drug,
Whether there is any criteria for drug-induced liver
single drug,
autoimmune
one
disease. Yeah.
autoimmune hepatitis. Yeah.
Is there any difference in the regime for drug-induced autoimmune liver disease versus the classic autoimmune hepatitis? Because that's an important question
We
also.
need to
Because
know that.
yeah, that's it. And Dr. Charles, summing up about the case, about their presentation and about the case, and some important take-home messages.
Yeah, very good case, and probably Nihal was biased by the fact that he knew the diagnosis of drug-induced when he initially discussed the case. Always remember to keep a broad differential diagnosis. Don't confine yourself to a few, and always never say it cannot occur. Okay, always keep it down. All the rare things, you keep it down in the list, and okay, you'll just say that you will consider, even though it's less likely. And about the case, it could still be a drug-induced liver injury. You're seeing, as Madam said, there's no interface hepatitis. You're seeing a lot of eosinophils. Looks more in favor of a drug-induced liver injury than autoimmune liver disease here. And maybe you will be able to stop the steroids and watch the patient closely instead of putting them on long-term steroids and azathioprine.
Okay.
And just read all that Dr. Charles UCAM scoring, R scoring, what is Hy's law, all this should be on you. Getting the patient is having a mixed cholestatic jaundice, mixed type of jaundice, or is having cholestatic predominantly, or is having a hepatocellular. That's the way you respond. And then when we ask you, when you have doing a liver biopsy, what is there in your mind? What is it that you're looking for? What do you expect the pathologist to give you a report on? With the correction of the mild derangement of the coagulation profile, then what is ALI, when you say it's ALF, all these things are very, very important. So just read up this, and the last bit, as I said, the duration of management of these patients, whether it is drug-induced autoimmune vis-a-vis de novo autoimmune hepatitis, is something that you should know. And the thing is, once you get a bias, know that is levofloxacin. Actually, the person who's presenting should just be the presenter, and the other two are people who should not be knowing the diagnosis, and they should be discussing. Because then you get biased, then your mind does not work at all. Once you know the diagnosis, then it becomes, your mind does not work at all.
Yeah,
next time onwards,
we have
present and let them.
Okay, we'll follow that system. The candidate will present, because the candidate who actually takes the pains to take the case also would love to discuss it. That's why they should get maximum benefit for having taken pains to find a case and present it, etc. Because
no, but if he's true to his conscience, then he should not know the results. Okay, I'm very clear about that here. So what we do is, we have from the same unit two people, one taking the history, the other taking I mean, you have to be true to your conscience if you really want to do a good job. Otherwise, mind will not work. Just does not work. As Dr. Charles said, he already knows what it is. Then your mind does not work. All the time he was concentrating only on autoimmune. Just look at that, which is absolutely wrong. You have to give a wide differential. That's why when I came in for the summary, I did not understand what was happening to the patient. So be very careful. We're just giving you some tips and certain suggestions that happens in the exam. It's only for that reason. Okay.
This is how examiners actually find out whether you have got tip, not tip or tips, whatever it is. Okay, your diagnosis will hover around a couple of 1 or 2. You will not expand your differential diagnosis under whatsoever pressure. We will keep on asking you, but you will not improve on your list. And finally, the diagnosis will be exactly what you told. Then we know that you have got enough internal information. Okay. That is how the examiners pick it up, that your list of differential diagnosis is too narrow. And Inspector given a lot of clues, you still don't want to expand upon it. We have a couple of comments and questions in the chat box. I think we'll just go through it. And Shobhana ma'am has asked us about viral hepatitis. Can this have been a viral hepatitis without a prodrome? Dr. Charles, is it possible? I think so, no?
It's possible, yeah. As Madam said, there's A to Z now. So
Yeah.
many of them
It
can
is
present
possible.
without.
Okay. Fever to jaundice was less than 2 weeks, so more than could fever be a part of the symptom? So I didn't understand it. If anyone else understood, you can answer that. Could it be
Fever,
acute?
Drug-induced liver injury can present with fever, no? As a hypersensitive reaction.
Yeah. Should anti-HBC should have been done in this patient? I think for a complete workup, I think Wilson was missing. Wilson workup was not mentioned, I think. That also should have been done.
was normal, sir. I've not written
Is it? Yeah, but it should, I
Yes,
think you
sir.
should write it down, because in any patient with
Yes, sir.
acute presentation also you should, Wilson also should be there. Is vitamin K going to help if this is not a cholestatic type? I think what in clinical practice, even in parenchymal liver disease, when you give vitamin K, it improves, because not all liver cells are completely damaged at the same point of time. Some cells are functioning, some cells are defective. So cells which are functioning can be expected to work more when you force it on with a little overdose of vitamin K, and means that cell will get exposed a little more. And in a biochemical reaction, it is possible that even in parenchymal liver disease, the coagulation profile may improve. That typically it may be seen in a chronic cholestatic disease.
So can I ask you in a different way? This patient with INA 1.7 has responded to vitamin K after 3 doses. Would you still call it acute liver injury?
Theoretically, I won't. In fact, what I would consider in my department, when a patient is absolutely stable and is vitamin K, and if the INR is appearing elevated, I will ask them to redo it under appropriate proper condition. This is perhaps the only test in the lab where if the quantity of blood taken or drawn into the syringe is slightly different, the values will be vitiated. That I have found. Because it has to be exactly, I think, 1.4 ml or something like that. If it is slightly more, slightly less, the value will be abnormal. So I always used to tell my student, if the patient is hale and hearty and nothing to suggest liver injury, and if the INR is elevated, please repeat it rather than jumping to make a diagnosis of acute liver failure or anything, because the error can be there. Okay, that is also possible. What I would suggest is, instead of calling acute liver injury, they should have called it acute severe liver injury. It would make, because in any case, if there is an acute liver injury, even for an ordinary acute hepatitis, sometimes nomenclatures can be confusing. I have been thinking about this for quite some time. Okay, I think, do we have anything to say? Shobhana ma'am, anything to add? Shobhana ma'am?
Really nothing, because I think you've summarized everything. Just at the start, we talked about, he should not have known the diagnosis because he kept on harping on drug-induced liver disease. Secondly, when you come to a differential diagnosis in such a patient, start with saying that I'm thinking of either intrahepatic or extrahepatic liver disease, because nothing in the history is helping to differentiate the two. And like Dr. Jayanthi ma'am had already, given all those details. And finally, of course, in the diagnosis, though autoimmune hepatitis does have those positive and negative points, a very borderline ANA like a 2+ is not really helpful. So liver biopsy would be the ultimate answer. But again, in a clinical situation where, the patient is not decompensating, the bilirubin is high, otherwise the patient is stable, maybe waiting for a few weeks would not have changed much in this patient. No, that is more from a clinical perspective that I would like to say.
Yeah, in the era of medical litigation and all, perhaps it will be safer to err on the overcautious side, because if the patient had otherwise become worse and has developed some problem, we could be sort of dragged into litigation. So playing it safe may be ideal in this current scenario, even though it may not be absolutely sort of clinical clinical. Okay, that's what I feel. But I think we should congratulate our residents for taking up good cases and presenting. Nihal Ali, you have made a wonderful attempt. And only I just have to say that please listen to your examiners. Please listen to your examiners, understand their questions well, and then only try to answer. Otherwise, because they will feel also offended because you are not trying to listen, no? Because this part perhaps you require little more training, but otherwise you have made a good attempt of presentation, and keep on trying to present more, and I am sure in the end you will be a great clinician. Okay.
Thank you, sir.
So we have criticized you, we have interrupted you, we have made harsh comments upon you without any bad intention. It is only to make to see that you perform very well in your examination. Okay. So that
Thank you.
the same mistakes won't get repeated in the examination. Okay. So our intention was only that, and we don't have any other intentions. Only to
Yes.
see that our students improve and perform perfectly well in their examination, so that you'll get a very easy pass in the examination. Or rather, the examiners will get rather, it is actually very pleasurable to sit in an exam hall and listen to students who know the stuff and present it in a beautiful way. And we rather enjoy the way in which you people present a good case and thrash out the differential diagnosis and all. Okay, so we want you to be like that. And also thank the other two discussants. And of course, there was one more case to be presented, but we will do it in the next session. So thank you, Dr. Charles, for taking time out to be with us. In spite of your very busy schedule, I am sure Dr. Charles will have lots of your transplantation lined up. You have to attend those patients post-transplant. In spite of his busy schedule, he has consented to be today's faculty. Thank you, Dr. Charles, for your kind-heartedness, and I will look forward to your continued cooperation. And I want to thank senior professors like Shobana ma'am from Mumbai and Jayanthi ma'am, who is always the pillar of support for our class, and Dr. Ajit Taragan, who has been extremely helpful to find out rare articles and post it in our WhatsApp group. Dr. Ajit, please continue to do that. And I also thank all other faculty members who have been here and all other residents who have taken pains to attend this class. My again advice will be that present lot of cases locally in your institution between yourself and try to present it in various forums also. With all this, I thank you, and we will close the session. Thank you very much.
Thank you,
Thank you.
Dr.
Thank you so
Charles.
much, sir.
Thank you, Dr. Charles. Thank you, Dr.
Thank you, ma'am.
Thomas.